Well, hello everyone, and welcome to the Sleep Grand Round sponsored by the American Academy of Sleep Medicine Foundation. Today we have Dr. Raj Dedhia from the University of Pennsylvania joining us to discuss hypoglossal nerve stimulation therapy for obstructive sleep apnea and blood pressure. Before I formally introduce Dr. Dedhia, I will remind you that your audio is muted and that your video is off. We encourage you to include any questions on this topic for the speaker in the Q&A section of the Zoom platform. And this webinar is being recorded and will be shared with everyone that registered for the webinar. And this webinar is approved for 0.75 AMA PRA credits. Next slide, thank you. The Sleep Grand Rounds aims to feature AASM Foundation funded work that addresses practice gaps in sleep medicine and sleep health. Per the updated Accreditation Council for Continuing Medical Education standards for commercial support, the ASM has implemented a process requiring each speaker to disclose and resolve all conflicts of interest with any commercial entity. We have reviewed the disclosures and resolutions and believe the submitted citations comply with the ACCME standards. The disclosures and resolutions provided by the speaker are included in the slide presentations for the attendees' information. Now allow me to introduce our speaker today. So Dr. Dedhia is an associate professor and director of the Sleep Surgery and CPAP Alternatives Clinic at the University of Pennsylvania in Philadelphia. He is board certified in both sleep medicine and otolaryngology. His research interests include upper airway pathophysiology and sleep disorder breathing, as well as the cardiovascular effects of sleep disorder breathing. His current research is currently funded by the National Institute of Health, and he is also a past recipient of the American Academy of Sleep Medicine Foundation's Board of Sleep Medicine Junior Faculty Grant, which was focused on understanding the effect of hypoglossal nerve stimulation on intermediate markers of cardiovascular risk. So thank you for joining us, Dr. Dedhia. I will pass the mic over to you.
Thank you, Vanessa, for the nice introduction. Nice, good to see your face. We got through the technical glitches. I think we should be okay to go. So I'm going to share my screen, and you let me know if things look okay to you.
Perfect. Yes, I can see the screen.
Okay. Welcome, everybody. I understand we have quite a few attendees, a lot of clinicians. So I'm going to try to keep this hopefully digestible to talk about both hypoglossal nerve stimulation and cardiovascular effects of sleep apnea, and talk about a trial that we recently completed with the two in mind. Okay, conflicts of interests, none that are relevant. This is a statement put forth for the ACGME. The objectives that I'll talk about are going to mirror the outline of the talk. So we'll start off talking about cardiovascular risk in sleep apnea, then hypoglossal nerve stimulation as a treatment for sleep apnea, and then really get to the nuts and bolts. And what I'm thankful for the ASM for funding was our trial looking at cardiovascular outcomes in hypoglossal nerve stimulation. Okay, OSA. We all know it. We all see it. We see it in a bit of different light here at Penn. This is from our sleep endoscopy tracing, where we have physiology during the sleep endoscopy. And what you guys can all see is that there are, okay, so we've got nasal flow on the top channel, our epiglottic catheter, which is essentially a pressure measure, oxygen, and the pulse rate. And in a typical obstructive apnea, there's no airflow, there is increasing respiratory effort, and a gradual desaturation followed by a resaturation, as well as a spike in heart rate. So keep that in mind as we now talk about what causes atrial fibrillation from untreated sleep apnea. The mechanism is very similar to what I just showed you. It involves these three signals from our sleep evaluation. Negative intrathoracic pressure swings. So every time you see this downward deflection of the epiglottic catheter, that is increasingly negative pressure that's exerted on the heart and the lungs. You see a desaturation followed by a rapid resaturation, releasing free radicals and inflammation. And thirdly, you see adrenaline and noradrenaline, which is released, and the form of that here is with increase in the heart rate. So this is the perfect milieu for things like dysrhythmias and almost anything else that we talk about in cardiovascular risks, high blood pressure, stroke, other things are formed from this type of environment. So I'm going to talk about the sleep apnea and cardiovascular risk in three major trials or three major observational studies that we've seen in our field. Sleep apnea is a pretty young disease compared to other things. 1965 was described. Treatment came out in the early 80s. Following treatment, we saw three major observational studies that have really informed our understanding of how sleep apnea affects the cardiovascular system. The Wisconsin sleep cohort, the Spanish cohort, and the sleep heart health study. I'll be referencing them in the next few slides as we talk about what we really understand about sleep apnea and cardiovascular risk. And again, as clinicians on this call, as most of you are, we have to personalize our recommendations to patients. And we can't just say sleep apnea is going to mess up your heart. That's really not an educated statement. It depends on three different aspects at the very basic level. How bad is sleep apnea? Who's the patient? And what are their symptoms? So let's talk about sleep apnea severity. This is a table that I made from the Spanish cohort study from about 10 years ago, where they looked at what was the effect of AHI on incident or newly diagnosed high blood pressure. This is a follow-up of 12 years, and they've adjusted for everything under the sun that you can imagine in the adjusted model, from age to alcohol use to blood glucose. And what you can see is that as the AHI increases, in this case, and they're not treated with CPAP, so in this group, ineligible for CPAP or declined CPAP, the rate of incident high blood pressure goes up by 33% or even doubles in those with higher AHI values. You can see, of course, in the final column, if you're treated with CPAP, no matter what their AHI was, they actually had a decreased risk of high blood pressure. So severity seems to matter. It matters not just for incident high blood pressure, but also for stroke. This now is from the Sleep Heart Health Study, looking at how AHI severity in this top row influences the risk of stroke. So let's look at the fully adjusted model. Again, this is a 9-year follow-up, adjusted for all kinds of things from high blood pressure, diabetes, smoking. And you can see here that as you increase the number of events per hour, the AHI, you have an increase, especially over 19, of stroke, almost triples your risk of stroke in that population. So worse sleep apnea, the worse the outcome. What about gender and age? We now see a wide diaspora of patients from young to old, males to females. In this Sleep Heart Health study, male gender was associated with cardiovascular, with in this case, coronary heart disease. Again, 9-year follow-up. Males are on the top rows, females on the bottom rows. And what you can see is as the AHI increases, mild, moderate to severe, in men, you see a linear relationship of risk of coronary heart disease. In women, however, you don't see the same relationship. Almost, it's paradoxical, where the people that women have more severe sleep apnea have a less likely chance of developing coronary heart disease. Now, how can we explain that? That doesn't seem very biologically plausible. Well, a couple things. One is that we know that menopause is a major driver of sleep apnea because of the loss of progesterone. So the exposure window for women is less than that of men. So that's one, very understandable reason why we see that. And also, I should make note, this was a very small number, 84 patients. So, take it with a bit of a grain of salt, but it's pretty clear that the effect in women is different than that of men. And what about age? This is, again, as we see patients, as I'll talk about for hypoglossal nerve stimulation, that are older patients, this is pretty relevant. So again, in this model, when they looked at men under 70, again, this was an older Sleep Heart Health Study cohort, but men under 70, that risk really showed up. So in the younger patients, again, relatively younger, we see more of the cardiovascular risk than the older patients. Finally, what about symptomatology? Sleep apnea presents in all kinds of ways, from poor sleep to no symptoms to sleepiness. This is work from our group here, from Alan Pack and others at Penn before I was here, but looking at the Sleep Heart Health Study, the secondary analysis. And they looked at the excessively sleepy group. These are patients that had very dramatic Epworths of almost 14 or more, and looked at how they fared compared to other patients as far as incident cardiovascular disease. And compared to those that were minimally symptomatic, who complained of disturbed sleep, or even who were moderately sleepy, they had more than double the risk of incident cardiovascular disease if they were excessively sleepy. So I want to, again, start by just summarizing the risk here, the way that at least I interpret the world of sleep apnea and cardiovascular risk. If you have patients that are young, sleepy men with severe OSA, these are the ones that should really drive us to think about how we can reduce their risk of excess cardiovascular risk from sleep apnea. Part 2 of this talk. He's going to really try to get, again, most of you, I assume, are not doing nerve stimulation, but maybe you're referring patients or treating the patients on the back end. But let me give you a little bit about what this therapy really is. So it's an option, of course, for the PAP intolerant. And this is essentially how it looks in the patient. We see the implantable pulse generator that's located in the right upper chest. There is a stimulation lead that's tunneled into the neck to stimulate the hypoglossal nerve, and a sensing lead placed somewhere in the chest area that is going to determine or detect pressure changes so it knows when to fire. This is a nice animation showing that as the stimulation is given to the hypoglossal nerve in those fibers, the tongue anteriorizes and opens up the airway. Who qualifies? Currently, the FDA criteria stipulate patients over 18. I've highlighted in red the recent changes in the last few months that some of you may not be aware of. The BMI has now been pushed to 40 from 32, and the upper limit of the AHI has been pushed from 65 to 100. So there's, controversy around these changes, but these are the current changes put forth by the FDA. Patients have to have been described as a CPAP failure. That could be something as they're unwilling to use CPAP, or they've tried CPAP, or they have tried CPAP and they still have a high AHI. These are all different types of failures. They need to undergo something called a drug-induced sleep endoscopy, during which there cannot be complete circumferential palatal collapse. I put here an asterisk what I consider in my population when people have very bad sleep onset insomnia. We should be careful because these people may have a hard time falling asleep, and or the stimulation may worsen their sleep onset insomnia. What can we expect as far as outcomes? This comes from the STAR trial now almost a decade ago that was published looking at median values of the AHI and the Epworth Sleepiness Scale. The median AHI drops from 29 to 9 and the Epworth from 11 to 6. I will remind people that's the median values. If you look in the text, you'll find the mean values, which are a bit different. The mean values show a reduction of 32 to 15 in the AHI and Epworth from 11.6 to 7. So less impressive, nonetheless, a 50% reduction in the AHI. What do we think about with patients before having a procedure like this? We let them know it's same-day surgery with general anesthesia. It now takes about an hour to an hour and a half for the actual procedure. The recovery, we still give them something like a Vicodin for a couple days they take, as well as other things if they need it. But typically just Vicodin, half people take that, half people don't even take the hydrocodone, they just take Tylenol. And they're back to school or work in a few days. So the recovery is fairly straightforward. There are risks, of course. Asymmetry of the lower lip, pneumothorax and infection being more rare. Side effects are dry mouth and tongue abrasion, among others. So in the OR, this is a patient of ours that was prepped in the usual fashion. You get a sense of what it looks like. This is the incision for the neck and the incision for the chest. We mark out the second and third ribs to put the generator in that pocket. In the OR, this is a very, I would say, sophisticated procedure because we can really see the nerve very well. And you can see here, these are the retractor branches, these are the inclusion branches. And so we have a very good idea of placing the cuff in a way that it protrudes the tongue rather than retracting the tongue. And you get that experience at the end of the surgery. This is probably the most gratifying part when you peer in and you can look at the patient's tongue motion. It's not very subtle, but it shows, again, that nice unhindered protrusion of a stiffened tongue. We also check the sensing lead. This is from the operating room as well. And you can see this nice rise and fall, which is capturing each breath. So this is inspiration, expiration, inspiration, expiration. And these lines are telling you when therapy is on and off. So we all check that in the OR. So we leave the OR with confidence therapy is doing what it's supposed to be doing. The post-op timeline, it looks something like this for a patient. They get a post-op wound check. I now do all that virtually, which is great for patients. They get activated a month later at clinic. Our nurse calls them at 2 months for a check-in by phone. They come back at 3 months to review symptoms, as well as undergo a supine awake endoscopy, really to look at the tongue-based motion with therapy. If things look good, we schedule them for a titration PSG in the lab. They come back a month later to review the sleep study. And then at 6 months or 12 months, we want to get a full night study at a single voltage in their home. This to me is the best way to really understand what it's actually doing rather than monkeying with the settings all night in the lab. It's a single night in their own home. We can really get a sense of their efficacy of the therapy. And then at 12 months, we reviewed this home sleep test. And then in our case, we transferred to care to sleep medicine for annual checkup. But at that point, it's yearly follow-up until we say the 11-year date I have with the patient for the battery change. And that's done in the OR under local anesthesia to swap out the chest battery for a new battery. So hopefully that gave you a sense of what happens with a typical patient undergoing hypoglossal nerve stimulation. The last part that I really want to focus on is what the AASM funded me to do for over 3 years was our randomized control trial, and trying to understand how does hypoglossal nerve stimulation improve cardiovascular health in our patients. So as we know, PAP is rather efficacious, meaning the residual AHIs on our patients are typically less than 5 on the downloads, but we know they struggle on average with usage. Hypoglossal nerve stimulation is less efficacious. We don't see the same AHI reductions, but patients use therapy longer than CPAP. So our research question was fairly straightforward in that what is the effect of hypoglossal nerve stimulation on measures of cardiovascular health in patients with sleep apnea? So we chose to look at, there are different methods to measure cardiovascular health. We wanted to look at both mechanism and clinical outcomes. So we settled on 24-hour blood pressure as our primary measure, primary outcome in the study. But we looked at more mechanistic things, such as pre-ejection period, which I will describe, as a measure of sympathetic excitability. We also looked at flow-mediated dilation to look at vascular dysfunction. So I'm going to spend a couple minutes talking about each of these measures. These aren't clinically used, so I wanted to make sure the audience understands what they are. 24-hour blood pressure. This is a device that samples blood pressure every 30 minutes during wakefulness and 60 minutes during sleep over 24 hours. This avoids the white coat hypertension that occurs in the office and also provides multiple data points, including while the patient's asleep. Here's a photo of one of our research coordinators, and you can see the cuff on the patient's left and the monitor on the patient's right. And you can see this is sort of worn. It can worn through the shirt, under the shirt, but it should be on for 24 hours to get good data. The link between PAP therapy and blood pressure is well documented. The Spanish sleep cohort reported that 24-hour blood pressure improves with PAP therapy in a dose-response fashion. You can see these two panels. You've got CPAP on the x-axis, systolic and diastolic blood pressure here on the y-axis. And you can see the trend lines, albeit with some variability, showing that you have a decrease in blood pressure, the change, as you increase CPAP for both diastolic and systolic blood pressure. Pre-ejection period. This is a measure of sympathetic activity defined as a time between an electrical and mechanical systole. To measure pre-ejection period, we have to capture both EKG or ECG, which we know, and impedance cardiography, which is a research tool. Here's a photo of one of our patients, and you can appreciate the placement of the electrodes, which are part of the ICG or impedance cardiography signals. Our third measure was flow-mediated dilation, which is a measure of vascular health, and it's measured as the increase in brachial artery diameter. It's a convenient tool because it only takes 5 minutes to perform, and it's also sensitive to interventions that affect vascular health, like HGNS or CPAP. In this photo of our patient, you can see that the blood pressure cuff is applied around the forearm, and the ultrasound probe is placed over the brachial artery. Moving into our study design, there are 5 important features of our trial. The trial was double-blind, sham-controlled, randomized crossover study. The study started at Emory, but as I moved to Penn in 2019, we moved it here to Penn. We also recruited local institutions like Thomas Jefferson to participate. The main inclusion criteria included already having an Inspire device and using the device regularly, as defined as greater than 20 hours per week for more than a month. Patients were excluded if they had older remotes due to limited adherence capabilities. Our team was able to provide remotes for those patients to help increase the number of patients enrolled. Patients were also excluded if they had fallen asleep while driving 1 year prior to their implantation. Now remember, as I said earlier, we want sleepy patients because those are the ones with cardiovascular risk. But this really gets at one of the challenges with these types of trials when you're trying to keep patients safe, and therefore you might not have access to those people that really are the ones that benefit from a cardiovascular perspective. This is a high-level view of the study, starting with standard of care and ending up with study wrap-up at the start of the 11th week, again, a 10-week study duration. When patients were determined to be in a steady state usage with their therapy, they were approached by our team for the trial. If they were eligible and agreed to consent, they underwent a 1-week washout without any therapy. The device was programmed at 0.0 volts, so they wouldn't use it at all. After the 1-week randomization, patients returned to clinic for randomization to enter either sham or active therapy first. Our research team performed block randomization using a sealed envelope technique. The nerve stimulator device was then set to either sham voltage or an active voltage, and patients were asked to use that for the next 4 weeks. So what is sham and active therapy? To determine sham therapy, the device was set to a voltage at which either bulb tongue motion was observed or the patient reported feeling some kind of motion. Active therapy was determined by their clinically set voltage by the treating clinician. So here's some videos of what sham therapy and active therapy looks like in one of our patients. Now, I will say it's not all patients have such a dramatic difference visually, but this is a good example to show you sham and active. So I'll start with the sham video. You saw that little push forward of the tongue and the reset backwards. That's the sham therapy. Now, active is much less subtle. This patient really darts forward, and that's the active therapy. So after 4 weeks of using either sham or active therapy, patients returned to clinic to undergo cardiovascular testing. They then underwent a second 1-week washout to eliminate any carryover effects from the first half of therapy and were crossed over to what they didn't get. So if they were sham first, they were active second, and vice versa. They came back for their final visit to undergo a second round of cardiovascular testing. Here's a consort diagram showing we had screened 156 patients from 3 different universities, and we ultimately enrolled 63 patients. 3 patients did not complete the study, so we were successful in our target goal of 60 patients for the study. Our study population was generally older, male, not sleepy. Again, Epworth of 7, we think of 10 or more as being sleepy. Predominantly white, overweight, and half of whom had high blood pressure and a quarter of whom had diabetes. Our primary outcome measure, 24-hour blood pressure, showed no difference. Here you can see, I'll show several box and whiskers plots. The line in the box represents the median value. The edges of the box represent the 75th percentile, the bottom 25th percentile, and the whiskers represent 1.5 times the interquartile range. Here's an outlier, for example, in this one. The X represents the mean value. So a lot of information contained in the box and whiskers figure, but you can see, even looking from across the room, there's really no difference between active and sham for 24-hour systolic blood pressure, nor 24-hour diastolic pressure. As far as our secondary outcomes, pre-ejection period and flow-mediated dilation increase, again, there were no significant differences between the active and sham therapies for either outcome. We decided to investigate factors that could explain these results, and we looked into AHI responder status, which we defined as a 50% reduction in AHI from the pre-implant or baseline AHI. Now, the active group had a responder rate of 65%, which is almost exactly what we saw in the STAR trial, which was not surprising. But what was interesting was that the sham group, in the sham arm, we saw about a 50% responder rate to what we thought was sham therapy. So we then performed a per-protocol analysis to look at what happened in these patients who really improved in a way that we expected. So we defined the per-protocol sample as patients that had a 50% reduction in AHI between their active and sham interventions. And this yielded a subset of 20 patients out of the 60 that actually had what we thought was the intended effect of the sham and therapeutic arms. So now we look at the AHI differences. And the intention to treat analysis compares AHI across study conditions. Here you have the baseline on the left, the sham here in yellow, and the active arm in blue. And we see that the pre-implant AHI and the sham AHI were statistically different in the intention to treat analysis of all 60 patients. It was also different between the sham and active group. So this suggests the sham wasn't a true sham because it was quite different from the baseline or untreated AHI. By contrast, in the per protocol analysis, you can see that the pre-implant or baseline AHI was not different, statistically speaking, from the sham AHI. Meanwhile, the sham AHI was much higher than the active AHI. So again, it gave us confidence that this per protocol analysis was really the patients whom we were trying to identify as having that effect from sham versus active therapy. So now when we look at the data, looking at both intention to treat in all 60 patients, as well as per protocol analysis, we see slightly different findings. So the left-hand column here compares all of our cardiovascular outcomes, followed by the difference in sham versus active in intention to treat, followed by the difference in sham and active in the per protocol sample. So the greater the blood pressure, now greater blood pressure values are associated with poorer health outcomes. So we expect to see a positive difference between sham and active therapy. There's not much difference here between sham and active in the intention to treat arm, but we see a more pronounced difference in the per protocol sample. In contrast, for pre-ejection period in FMD, these are associated with better health outcomes. We expect a negative difference between sham and active arms. Again, a negligible difference in the intention to treat analysis, but it becomes more pronounced in the correct direction in the per protocol sample. So there are several strengths to our study. This had a sham-controlled design, which is very difficult to do in surgical trials, but we took advantage of the fact this is a medically implanted device that allows us to do those kinds of manipulations. Other strengths are listed here. We have had limitations. Some of these we knew going into the trial. For example, this only applies to people that are candidates for hypoglossal nerve stimulation, not the entire world of OSA patients. We didn't have true baseline measurements. We only had a sham and active. We included both normotensive and hypertensive patients, which might have blunted our signal as we had normotensive patients. As I mentioned earlier, I can't overemphasize this, we did not include patients that were very sleepy. But as you know, when you do a trial, you learn things on the way. Of course, the biggest finding here was that sham, what we thought was sham, was actually partially therapeutic. We had a hard time recruiting those people who love their Inspire. Oh, it changed my life. Oh, I can't live without it. And no, I'm not going to do your trial because I'm not going to part ways with it for 10 weeks. We did do a blinding adequacy assessment. We found that blinding was largely ineffective. People knew what they were getting. Our subjects were largely older and of white race. And finally, we had an institutional transfer amidst a COVID epidemic, which slowed things down quite a bit. In summary, 24-hour blood pressure was not significantly different between sham and active therapy in this randomized controlled trial of hypoglossal nerve stimulation patients. The per protocol analysis demonstrated an increased, but still quite muted, signal for cardioprotective role for hypoglossal nerve stimulation. And finally, the therapy presents challenges for a sham-controlled trial, but we think we've learned a lot from this to help inform future trials. For example, setting the sham therapy to a true sham at 0.0 volts would avoid the subtherapeutic effect and we're giving it a true sham. And we need to find a way to increase incentives to recruit those people that just adore their therapy, that don't want to part ways with it, as well as those that are really at risk, which are the younger patients that are quite sleepy. This was a team effort over the course of 5 years that involves several different institutions. I specifically want to highlight Akshay Tangatur and Raj C, who are research coordinators who really helped do the legwork to make this trial happen. Thank you, and I will turn it over to Vanessa.
Well, thank you so much, Dr. Dedhia. We do have a couple questions in the Q&A, and just as a reminder to our attendees, you are more than welcome to put some questions in there. But the first question that we did get early on was, how many patients have complete collapse of airway and not eligible for hypoglossal nerve stimulation?
Okay. Yeah, thanks for the question. I think the question is probably referring to how many people have the complete concentric collapse of the velum, and that's circumferential collapse is a contraindication to Inspire. It depends on who you're asking. I don't know if they're published. The data that are published seem to be quite variable. In my practice, it's about a 15% rate of patients who are coming for Inspire that have that unfavorable collapse pattern on sleep endoscopy.
Well, thank you. The next question that we did get was, do you have any experience in patients with a BMI of 35 to 40? And then the second question for that is this effective in this population in your clinical experience, and are there any adverse events?
Yeah, thanks for asking that question. And that's sort of been very in vogue now because of the pushing the limits of the BMI up to 40. I have many thoughts on that. I'll try to keep it brief. First, typically if a patient has a BMI of 38 or 40, I'm thinking there really needs to be a weight loss component before treating the sleep apnea. So we try to discourage those patients. I will say there's two exceptions to that. The first are patients with Down syndrome. I see a lot of those patients, and they really have a different BMI curve. So I think it's not fair to hold them to BMI of 32. So if a 34, 35, I have done those patients with good results. The others are those that are really, I would call them the bodybuilder type, that really don't have a lot of body fat, but are quite muscular with BMIs of 35 or 36. I don't have as much experience with that. We've had mixed results with that patient cohort. So I think it's the BMI, again, one aspect is do they have a comorbidity like Down syndrome? The other is where do they carry their weight? I think those patients with larger necks I think of as less favorable candidates. Those potentially like the pear-shaped phenotype may be more appropriate because of again, the upper airway being less involved with the weight distribution.
Perfect. Another question from the same attendee. Any instances of respiratory failure due to use of hydrocone after surgery? And then it goes on to say that these patients may not be using CPAP by their inclusion criteria. Do you think one should observe in the hospital for initial 24 hours?
Yeah, and I think thanks for the question again. There was a lot of hesitation when I started doing this about 9 years ago, and I kept the first patient overnight. The same thing. I thought this is a severe OSA patient. I can't send them home. I think it depends on a couple factors. Of course, if there are really important comorbidities, for example, if they have hypoventilation or other things that make them, higher risk for post-op complications, it's okay to keep them overnight, or I would say at the very least extended stay in the PACU for recovery. Generally speaking, we use something called TIVA here, which is total IV anesthesia. And they wake up very quickly. They get propofol and remifentanil during the OR, and an hour afterwards, the surgery, they're wide awake, talking, breathing fine. So I think if people have extended anesthetic, processing, and they take a while, then I would, keep them overnight. But I think it's a very safe procedure to do as an outpatient, even with hydrocodone, as long as it's being taken judiciously. That's okay. I also advise everybody to sleep semi-upright after surgery. I think that's another important piece to limit some of the potentially grave complications of having airway obstruction if they're laying flat on their back after having anesthesia and severe OSA.
All right, and then we also have another question. This one's actually really related to the work that the foundation supported. So is it possible that blood pressure is sensitive to hypoglossal nerve stimulation therapy or OSA control overall? This would suggest any therapy being advantageous to reduction in blood pressure.
Blood pressure is sensitive to HNS therapy. I think, let me try to understand that question. I'm not sure I understand the question, so maybe that person can clarify what that means.
Yeah, Adam, if you're able to clarify, just go ahead and put in the Q&A your clarifying question. But in the meantime, there is another question that came up. So how well does hypoglossal nerve stimulation work in REM OSAs, especially because DICE does not represent normal sleep and it will not show similarity to REM sleep?
That's right. Yeah. Thank you for that thoughtful question. We think about REM as being hypotonia or atonia, and you think if you can give somebody stimulation exogenously, that would really help rescue the airway. It works moderately well. And if you look at the STAR trial patients, that was a unique cohort because on average, the REM AHI was less than the non-REM AHI in that cohort. So it didn't tell us a lot about those people that we have that are REM predominant in OSA. And my experience has been it works, but again, it works as good at best as it does in non-REM. So it's not any better than it is in non-REM. And I think it's because REM is not just atonia, but it's discoordination. And if I just fire one muscle, but I don't fire the palatal muscles or the other muscles of, let's say, of the strap muscles, you're not going to get the same effect at rescuing the airway.
You. Now we did get a clarification from Adam on his original question on whether blood pressure is sensitive to hypoglossal nerve stimulation. His follow-up was sham and active therapy showed similar reductions. Would this indicate that any level of therapy being sensitive to blood pressure control?
I see. Yeah. So, I mean, Adam, thanks for the clarification. I think we saw that when we compared sham to active in the per protocol analysis, there's about a 1 millimeter difference between the two. So we didn't have a baseline to compare sham to. So I don't know if their blood pressure dropped with sham or not. So we don't have that analysis available. So I can't speak to that. I think what we can say that sham therapy does have an improvement in the AHI and maybe a very mild improvement in the blood pressure, probably less than 1 millimeter of mercury.
And he says, thank you. All right, there's two questions related specifically to the hypoglossal nerve stimulator. One of them is if it's contradicted to patients with hypoventilation. And the other question is for another set of patients, any problems with patients with teeth grinding?
Let me start by the question with hypoventilation. So, we see a lot of, so one thing is a lot of our patients that are coming here are older, and with older patients, we see things like hypoventilation. And I'm pretty quick to say that if it's really hypoventilation, the problem is gas exchange at the alveoli. They need to have their chest pressurized with CPAP. And this will keep the airway open, but it's not going to necessarily inflate or cause any kind of PEEP. And that's what these patients need. So I try to discourage people from getting Inspire or other sleep surgeries if they have hypoventilation, because I really want them to have their lungs full to help facilitate gas exchange for those patients. So soft contraindication, how about that? And the other question was teeth grinding. Yeah, I mean, teeth grinding is very common. Some people think there's nice data from a group that says this is a cycle because of it's a type of asphyxic response. And if you treat the sleep apnea, you treat the bruxism. I don't think that's true in my experience with patients. But I have a couple of people that are bruxers that have Inspire that say it doesn't really affect their bruxism. Again, that's just, I think, 2 patients I have. So that's my limited experience with that question.
All right, and these questions keep rolling in. We do have 5 minutes, so I think maybe let's see
I'm
how many
I'm
we
here
can.
all night, Vanessa.
So the other question that came through is, do you exclude patients with positional obstructive sleep apnea, AHI less than 10, in non-supine position?
Yeah, again, nice question, because the STAR trial, of course, did that, and now there's no mention of that in the FDA criteria. And we see, as you probably whoever asked the question, there are a lot, half our patients with mild sleep apnea are positional, about 25% with moderate to severe positional. That's a lot of patients. And I don't exclude them, but I will say we have an abstract we presented a couple months ago that we see a similar reduction in the AHI between supine and non-supine. So in other words, if their AHI goes from 40 to 20 on their back, it might go from 20 to 10 on their sides. So we see a similar reduction. In general, this therapy works best on the side or not on the back. But I think it's important to think about, because I often ask patients as part of our intake questionnaire, are you a side sleeper? And if they are, I get a little bit excited because we typically see better responses on the side compared to the back.
All right. So another question was, did you consider measuring Epworth Sleepiness Scale between therapy groups? Curious if patients in the active group had improved Epworth Sleepiness Scale over the sham group.
Thanks for that question. I didn't want to foreshadow. We have a paper that we're working on right now, looking at the same trial, looking at subjective measures, which is things like Epworth, as well as we did something called psychomotor vigilance testing, or PVTs, on these patients during those 2 different arms of the study. We've got data on that. In brief, the Epworth did improve by about 2.5 points between sham and active. So perhaps what the person's asking, and that's right, people feel better. They felt better on the active therapy. We just didn't see objective evidence of that, which is not uncommon in sleep medicine, as we know. But yeah, there was a difference of, I would call it clinically meaningful, about 2.5 points between the active and sham arms.
Okay, and this might be the last question that we take. So, what about the hypoglossal nerve stimulation effect in patients with normal BMI, but mouth breathing and lower jaw relaxed towards the back? Airways are then narrowed behind.
Yeah. Again, we see this a lot. So again, thanks for the question. During DICE, for example, we see a lot of people that have this sort of slack jaw appearance, and the tongue is falling back because the mouth is open. Um, and what we in those patients, we've actually had good results. And I think it's because when the mouth opens, it's typically the tongue that's falling back. And in these mouth breathers, if you can get the tongue out of the way, that's your only enemy. The palate is bypassed because you're breathing through the mouth as opposed to through the nose. So the tongue can be stimulated and pushed forward. We see these patients do actually rather well.
Great. Now you did get a shout out in the Q&A, so thank you for don't have a question, but just want to give you a shout out for this great talk, which I completely agree. All right. So on that note, let me go ahead and share my screen here before I let everyone go. So just want to thank you again, Dr. Dedhia, for taking the time for putting together this presentation, and also want to thank everyone who participated today. Uh, there will be an email sent out with instructions on credit claiming and also a recording of today's webinar. And as a reminder, this webinar is approved for 0.75 VRA credits. And sadly, this is the final sleep grand rounds for the year from the ASM Foundation. However, the good news is that a schedule with all of our new grant rounds will be released early in the year. In the meantime, I welcome you to view our upcoming ASM and ASM Foundation events by visiting our event pages. Thanks again for joining us and have a good rest of the week. Goodbye.